now we have one more presentation in international paper presentation that is non-competitive, and I invite Kapoor. She will be presenting a unique way of treating third nerve palsy with aberrant regeneration. Dr. Smita, all is yours.
Can you see my slide? Is my slide visible, sir?
Yeah, visible. You are audible. Please start your presentation.
I'd like to say good afternoon to all of you. This was presented at the Egyptian Association of Pediatric Ophthalmology and Strabismus Young Ophthalmologists webinar this year, and this secured the first position. So I'll be presenting a unique way of treating third nerve palsy with aberrant regeneration. So the slide is not moving. Okay, so before starting, I'd like to share the patient's consent. A 38-year-old female suffered from head injury in a road traffic accident 3 years before she presented to us. She was unconscious for 20 days and a CT scan showed a subarachnoid hemorrhage. On regaining consciousness, she was unable to open her left eye. This improved over a period of few months when she started noticing double vision and outward deviation of the left eye. So when she presented to us, her complaints were drooping of the left upper lid, binocular double vision, and outward deviation of the left eye. Her unaided visual acuity was 6/6 in both the eyes and intraocular pressures were normal. The left eye showed a moderate ptosis of 3 millimeters with poor levator function. There was no lag of thalamus. Bell's phenomena was poor and Marcus-Gunn jaw winking was absent. Hirschberg test showed a 15 degrees of exotropia with mild hypotropia. Cover test revealed a larger hyperdeviation and secondary hyperdeviation in the right eye. Extraocular motility was restricted in all the gazes. In up gazes, down gazes, and dextroversion, abduction and intorsion were normal. There was an improvement in palpebral fissure width on adduction, which is the reverse of what is seen in DUANE'S retraction syndrome. Hence, this sign is known as inverse DUAN sign. On down gaze, there is the pseudo appearance of lid lag, similar to what is seen in thyroid eye disease, hence called as pseudo von Graefe's sign. Both of these are signs of aberrant regeneration. In the primary gaze, she was able to fuse with 35 prisms base in and 5 prisms base up. Her left eye showed a 5 millimeters pupil and the right eye showed a 2 millimeters pupil, suggestive of anisocoria in the left eye, and fundus examination was normal. So a diagnosis of left-sided pupil involving traumatic third nerve palsy with aberrant regeneration was made. So by conventional treatment, the left eye should be operated by doing a lateral rectus recession and medial rectus resection, followed by the ptosis correction. However, this technique is a 2-step procedure and it is cumbersome. Resection is not very useful because the medial rectus has a nerve supply which is already compromised. And for any ptosis surgery, because of poor Bell's phenomena, corneal exposure risk is always there. So we did a lateral rectus recession of 7 millimeters in the right eye, along with a medial rectus resection of 5 millimeters and shifted the muscles down. Post-operative with orthotropia, the patient was diplopia free in the primary gaze and the lids were symmetrical. And this is the 2 years photograph which she recently sent to us. So aberrant regeneration is the misdirection of regenerating axons, which is usually seen after traumatic or compressive lesions of the nerve. This is the synergistic movements of the eyelid with eye movements. The other signs of aberrant regeneration are globe retraction on vertical movements, pupillary constriction on attempted adduction, which is known as pseudo-Argel-Robinson pupil, and ipsilateral adduction on attempted vertical movements. The first report of a similar case was published in 1980, where the normal eye was operated and improvement in both strabismus and ptosis was noted. Similar cases have been reported using adjustable sutures as well. So how does this procedure work? Weakening of the contralateral lateral rectus by Herring's law is going to cause an increased innervation to the affected medial rectus and thereby increasing an innervation to the LPS, alleviating ptosis. And by Sherrington's law, there will be a decreased innervation to the lateral rectus of the affected size, thereby reducing a chance of contracture. This technique also creates a fixation duress on its yoke muscle, that is the medial rectus of the affected eye, thus keeping the eye in an adducted position when the normal eye fixates. So in conclusion, I'd like to say that we should always look for signs of aberrant regeneration in third nerve palsy, because in such cases, by operating on the contralateral unaffected eye, it will be a promising option to correct both strabismus as well as ptosis in a single-step procedure. However, counseling of the patient regarding the decision to operate the normal eye is a very challenging thing to do. Thank you.
Smita, I think this surgery on the other eye in third nerve palsy is, I think, can you hear me?
Yes, sir. Yes, sir.
Is there for quite some time, and if you have aberrant innervation, it does work, but it has its limitations because third nerve, as you know, 4 muscles are gone. So there are at times torsional issues also if there is fourth nerve is intact. So one also has to look at that, is the fourth nerve intact or not, because it was traumatic situation.
Yes.
So that is one thing, and then you also have to see what is happening in up gaze and down gaze. And whenever we look at motility, we should try to give 9 gaze situations so that we know what is happening where. So it's a good thing. It helps ptosis and it also helps deviation. So this, by creating fixation duress, this works. But if you have aberrant innervation, which I think will work better in congenital situations, these acquired ones, they will have a lot of diplopia issues, which I mean are not always very simple to, I mean, they are difficult situations. So you were lucky that you had good results, but these are challenging situations, acquired third nerve palsies, because they have 4 muscles are gone and ptosis. So these are quite difficult situations.
Pandey, even in acquired, it works very well. And it is because the diplopia gets nicely corrected.
That's what I'm saying now. There has to be right amount of surgery and the response depending upon how badly third nerve has been affected, how much has been recovery. So these are, every case is different.
Basically, real challenge is to convince the patient for surgery in the normal eye, sir.
Yeah, that's another issue. Patients want that surgery should be done on the same eye. So that is also important.
Thank you, Dr. Smita. With this, we conclude this session.